with this, I invite my close friend, Rishi. Rishi, not only being a professor of cardiology at KGMC, my alma mater, he's a dynamic guy. He has a multi-talented abilities. In addition to an excellent academician, he's a great operator. And you really want to, because at one time the numbers were pretty less, but now almost nearly they're touching 1,000 plasties a month there in their center. He's going to be the head of the department very soon in a 6 months time. In addition, he's also attached with IIT Kanpur, and a lot of work along with, we both are also doing on artificial intelligence and so on. So I really suggest that, after you finish your things, please go visit him, try to be his fellow for a few months and pick up his points. Rishi, please.
Thank you so much for the kind words. I hope I deserve them. So, post-lunch session and 4 back-to-back exhaustive lectures. I am not sure if you guys are still, in alert state of mind. So let's do some physical exercises and see if we can wake ourselves up. Because what we are going to speak today next is something that is a little complex. But if you give me your attention, if you promise to give me your attention for the next 20 minutes or so, then I assure you that I would try to make things as simple as they possibly can, if not simpler. So how many of you are in the final year of your DM-DNB trainings? Final years? And how many of you have completed your DM-DNB trainings? How many of you have been doing independent PCI procedures, if I may ask? Okay. Okay. And how many of you have seen a PCI of anomalous coronary artery happening in whatever labs that you are practicing? No one? Raise your hands if you have. The rest of you have not seen PCI of anomalous coronary arteries happening in your labs? That's rare. As I said, a little raise of hand will... How many of you have seen PCI of anomalous coronary arteries happening? No. So that's an inertia effect. So I'm sure all of you would have seen one or the other cases where PCI of anomalous coronary arteries happen. It is no doubt a challenging situation, and it requires a little bit of philosophical understanding of PCI in order to approach, because it is not only purely application of skill, it is application of skill, knowledge, and a little bit of wisdom. So let's step back a bit from PCI to embryology. This is important because until and unless we understand this, we would not be able to understand the course and the various combinations of anomalous coronary arteries that happen. And trust me, there are very limited combinations that can happen, very limited course that can happen. But just because we have not studied them and understood them and read about them systematically, every time we see anomalous coronary arteries, our blood pressures start to go up and we start to feel a little jittery about doing the procedure. So essentially, in the developmental phase, the first thing to develop in coronary arteries structure are the sinusoids that developed in the first week of intrauterine life. And later on, all these sinusoids get reabsorbed or fuse with the stems that are developing in the grooves of the myocardium, that is the interventricular groove or the AV groove. So they become, either the sinusoids will get resorbed or they will become part of the microvasculature of coronary arteries. Now, when these sinusoids attach, the second component are these stems. The stems are 3 stems. They developed in the interventricular groove that later will going to form the LAD. The right AV groove, another stem forms, which later is going to form the RCA, and the left AV groove, which later on is going to become the circumflex. Now, further on in the development, there occurs the bulbs that developed in the bulbous cordis before its division into aorta and pulmonary artery. So there is a right bulb and there is a left bulb. That's you can call it bulb, you can call it bud, and they developed in the right and the left posterior quadrant of the bulbar cordis before it divides into pulmonary artery and aorta. And so the left two stems will fuse with the left bud. So left main will become left LED and circumflex artery. The right bulb will fuse with the right AV groove stem, and it will become the right coronary artery. Now, why is it important? Because some of the developmental anomalies of the coronary arteries are because of the non-fusion, non-resorption of the sinusoids. If the sinusoids do not get resorbed, what you will get? You will get a coronary cameral fistula. So the coronary cameral fistula is the non-resorption of the sinusoid, and that's why the fistula continues to happen. Another thing to remember is that since these stems are developing in the AV groove separately, embryologically and pathologically, they can never cross. So the coronary arteries, when they are taking an abnormal course, will make sure that they will never cross each other. And that's why it becomes, this fundamental knowledge becomes very important in deciding the course of the coronary arteries and you doing your procedures adequately. So these things we need to remember. And let's see, for example, the anomalous origin of the left coronary artery from the pulmonary artery. Now you have to remember that the buds develop before the bifurcation into aorta and pulmonary artery. So at the division, if the buds move forward, they will form the part of the pulmonary artery. And if the bulb continues to remain in the same position, they will form the coronary artery. So all this is very important before we step on to the percutaneous coronary interventions of the same. So there are various anomalies, the anomalies of the origin of the coronary arteries from the pulmonary artery, both left and right. There can be anomalies of the course, that is myocardial bridging and coronary aneurysms. There can be anomalies of the termination, that is coronary AV fistulas and coronary cameral fistulas. But for the purpose of our discussion today, we will limit our conversations to the anomalous aortic origin of coronary arteries, that is left originating from the right or right originating from the left. Are you all with me till now? Okay. So this is the conclusion slide. And let's put the concluding slide first. Just remember three things: that epicardial arteries can never cross each other. Whenever you are confused, the view to decide the course of the anomalous coronary artery is the RAO view. Whether it's the right or the left, it's the RAO view is the most important view. And the two biggest challenges of PCI and anomalous coronary arteries are guide engagement and guide support. Just remember this. Let's move forward. So let's take the example of anomalous circumflex from the right sinus. Now, the first thing that you will see whenever this anomaly is, you will see an abnormally long left main. Now, that is something that should at least raise a suspicion in your mind that it can be anomalous origin. It's not always the case, but it should raise your suspicion. So this particular branch coming out, is it a long left main and this is a diagonal, or is this a circumflex? What is the view to decide the anomalous course? The view, as I said, always and always, most of the time, the view that you have to fall back is the RAO view. You see the RAO view, and you decide here, this is the place where the coronary sinus should be. This is the place where your circumflex artery should be. That view is bald. So you know that this is a diagonal and you are not seeing a circumflex. Now again, what can be the three possible combinations? The three possible reasons here can be, there's a short left main and you have deeply engaged the left system and you are super selective in LAD. That can be one reason. Another reason can be twin origin of LAD and circumflex, separate origin close by, again a super selective LAD, and the third can be anomalous circumflex from the RCA, from the right coronary sinus, RCA, or close by RCA. So what you do is you disengage the guide, try to take the non-selective injections, and if on non-selective injections you still don't see the circumflex, either coming out from a short left main or from close by to LAD, your diagnosis is fairly certain that it is the anomalous circumflex from the right coronary artery. You go ahead and engage the right coronary artery. You will not see the circumflex. 9 out of 10 times you will not see the circumflex because your RCA guiding or diagnostic catheter would be deep seated inside the RCA. And until and unless you pull the catheter back and try to clockwise rotate it, taking the posterior view, you will not be able to engage it. So whenever you are suspecting and you are not seeing it, even in the RCA injection, pull back your guiding or diagnostic catheter, give it a little clockwise loop, and then you would be able to engage an anomalous circumflex coming out of the right sinus. Anomalous circumflex coming out of the right sinus will always have a posterior origin from the origin of the RCA. Either it would be from proximal portion of the RCA, or the ostium would be very close to the ostium of the RCA from a posterior location. Okay, now coming to the course. Can anyone of you tell me what are the possible courses of anomalous circumflex coming out of the RCA? How can it reach? What are the various courses it can take? Anyone? This is an important question. That's why I'm asking. Take a guess. How many courses anomalous circumflex can take to come back to the left AV groove? Any number? Yes, please. That's correct. There's only one course. There's only one course it can take. You try to see this embryological image again. The anomalous circumflex has to take its origin from the right sinus somewhere here. And if it takes any other course apart from the retroaortic course, it will have to cross either both RCA and LAD, or just the LAD or the left main system. As I told you earlier, major epicardial arteries can never cross each other. That is the first fundamental embryological principle of coronary arteries development. So there is actually, if you realize, you don't have to remember anything. There's no other way anomalous circumflex can take to reach the left sinus except a retroaortic course. And here again, as I told you, the second caveat, the second important principle was RAO view. When you see the RAO view, it's a poor cartoon, but in RAO view, the RCA falls like this straight, with the RV branches going forward. What the circumflex will appear like, it will take a sharp bend posteriorly and come back to the same plane, because in RAO view, you realize that the AV grooves, both left and right, are superimposed on each other. So whatever course the RCA was supposed to be taking, you will see the circumflex taking the same thing. I hope you understand that. So in RAO view, the left and the right AV grooves are superimposed. So this partial portion looks like an RV branch, and this is the turn that the retroaortic anomalous left circumflex has taken. So some examples, again, you see here, abnormally long left main, a bald coronary sinus segment, you don't see a circumflex, all the things that we have talked about. And that's inferior wall MI. When you try to pull back this tiger catheter, you see this faint contrast filling somewhere here, giving an impression of 100% occluded abnormalous circumflex artery. You try to engage it by Emplat's catheter, and then you do thrombus aspiration and standard PCI. Now coming to the second anomaly, that is the right sinus, right coronary artery from the left sinus. Now question number 2, anyone else? How many courses RCA originating from left sinus can take to come to the right AV groove? How many? 2, 3, 4, 5. Any guesses? Any number comes to your mind? Anyone? Madam, any number that comes to your mind? An RCA originating from left sinus, what are the various courses it can take? So that's the importance of knowing. You see, the RCA from the left sinus will arise from the anterior superior aspect of the origin of the LAD. And once it's there, you see, right coronary, right cusp is here. So RCA will always arise anterior to the left main origin. And if it is anterior to the left main origin, there is no other way. Here again, it's only one way. There's no other way except the interarterial course, that is between pulmonary artery and aorta. The RCA originating from left system, left sinus, will have to cross between pulmonary artery and aorta to come in the right AV groove. Because if it does any other course, it will have to cross the left main. And as you realize, major epicardial arteries cannot cross each other embryologically. So again, as with circumflex, RCA, even when it is anomalous, is a very disciplined artery. It will only have one course. However, it's not always so dangerous, because many a times it is picked up. Of course, if it's an acute myocardial infarction, you will have to engage that anomalous artery and do all sorts of primary PCI. But many a times we catch an anomalous RCA from left sinus as an incidental finding during angiograms. with no symptoms, no ischemia, and it is a benign artery usually. And even when it is interarterial, which I want to replace the term usually by always, RCA arising from left sinus is always interarterial course, but it is rarely malignant. It is almost always benign, but sometimes if it causes angina, if it causes blocks, if it causes VT, sometimes there are chances of sudden cardiac arrest. If all these things are present, then it is considered a malignant artery, and ischemia is produced not only by this anomalous, by compression between the aorta and pulmonary artery, but by variety of other things like slit-like ostium, intramyocardial bridging when it is coming between the aorta and the pulmonary artery, angulated origin, and associated CAD. So a lot of things combined make this artery malignant very rarely, but when it is malignant, then it needs to be treated surgically. The two big challenges in anomalous RCA PCI when it is originating from left sinus are guide engagement and guide support. Although a lot of guides have been described for guide engagements, but usually these guides are not present in most of the cath labs. So you can try with implants 1 or implants 2. That is the first choice. But many a times if it is not happening, there is a trick of actually modifying your JL or your implants in the cath lab, giving the tip an off-course 90 degrees turn which faces anteriorly. And normally it will not happen. You have to warm the catheter up. You can either dip it in the autoclave hot boiling water, or you can do a blower, the hair blower kind of thing, and you can put it over a guide wire and make the shape pointing anteriorly off course to the plane of the guiding catheter. And when you do that, then probably your chances of engaging an anomalous RCA are increased. And every year, probably once or twice, we will have to do this in our cath labs. So this is an inferior wall myocardial infarction. RCA is not found anywhere. And finally, by using implants, we are able to engage the RCA. And then, implants or angulated catheters, implants or Judkins may be used in this scenario. So the first problem is guide engagement. The second problem is guide support. You can do it by putting 2 wires, buddy wires. You can do anchor balloons. You can deep throat the guide by balloon support. And you should always use taut, short size, and very, very deliverable stents in such a scenario, because if you take long stents, if you take stents that are not very easy to deliver, then you will end up wasting a lot of time, a lot of contrast, and you will get a lot of radiation on the way. You see here, this is an example here. Anomalous RCA coming from left sinus. By great difficulty, you could engage it by an implants catheter. But you see the wire angulation coming. It is a very difficult wire, but every time you proceed forward, the wire comes back, the guiding is pulled back, the devices don't cross. When you put the buddy, just the 2 buddy wires are sufficient to push the catheter back. So again, you take a hydrophilic wire. I think this is Fielder XT. You take a Fielder XT across, take a buddy wire forward, and then you inflate the balloon while the 2 wires are inside. And when you inflate the balloon, it anchors your guiding catheter. Then you clockwise rotate your guide catheter and deep throat that guide catheter inside the coronary, inside the artery. And that is safely done sometimes even with RCA catheter, if you can engage it with it, and then you can deep throat, and then you can complete rest of the procedures. So guide engagement and guide support are 2 issues, but they should be, and it becomes really, it's too simple to look at, but it becomes very challenging when you do these cases. Coming to the third anomaly, that is the left sinus, left coronary artery from the right sinus. Now, unlike the anomalous circumflex and anomalous RCA, left artery is notorious. It can take any route. It can take a route that is anterior to the pulmonary artery. It can take a route between pulmonary artery and aorta. It can take a retroaortic route, and it can also take an intramyocardial route, the septal route, as it is called as. Which is the best angiographic view to decide the course of anomalous LAD? RAO. See, you guys know already. RAO. So there were only 2 things you have to remember. The the coronary arteries will not cross each other, and RAO is the view to fall back on whenever there is a confusion. So what do you see in that RAO view? You see, it's very simple. And if you remember How do you decide the course? Of course, CT is the gold standard, but if you don't have CT, one trick is you can put in RAO view, it's not a clear RAO, but somewhat RAO-ish view, your pulmonary arteries would be somewhere here. So one trick is you can put a pigtail in your pulmonary artery and then you can decide. But anyhow, the other view is the course of the artery. Now, if the artery is coursing, making a dome in the right superior quadrant of the artery, then the course is anterior to the pulmonary artery. This course is anterior to the pulmonary artery when it is making a dome in the right upper quadrant. And you see here, right at the tip where it is crossing the pulmonary artery, just the anteriormost segment of the heart, you see a critical lesion here. The other courses can be, if it makes sort of a sharp U in the left inferior quadrant, then it's the retroaortic course. If it makes a small U shaped upwards in the right lower quadrant and make a sigmoid curve and comes back like this, it is the intramyocardial, the septal version. And if it makes a sharp turn here, runs between the intracoronary artery, what is defined as, at this point of time, the arteries becomes end-on, which is defined as the I sign. If you see the end-on artery here as the I sign, and it makes a sharp bend and comes forward, this is the interarterial way, which is between the aorta and the pulmonary artery. So in contrast to RCA, interarterial course of anomalous LAD is usually malignant and should be surgical treated even in the absence of symptom. This is written in literature, but many a times we get, I recently remember I got a patient who was like 60 years old and who has some, mild degree of TMT changes. He has survived with this vessel for 60 years, mild degree of, ischemia on stress testing, nuclear testing. So I really don't know what to do to advise a surgical, treatment to him or not. He has survived with this artery for 60 years. So I'm scared. But generally speaking, malignant interarterial course of LAD should be surgically treated, even if asymptomatic, especially if you catch them in younger age groups. So there's again a myth. Sometimes we see that whenever we see anomalous coronary artery, it is only the right guiding catheter. It is not the case. You see here the anomalous LAD arising from the right sinus with the anterior to pulmonary artery course. We are struggling with implants. We are trying to get ahead, but it's not, the things are backing up. As soon as you change it to a right guiding catheter, then things become easy and you could complete the procedure. There are other rare cases where you have single coronary arteries, large size artery, which gives rise to both RCA and the entire left system. And we have this case where both LAD and RCA were diseased in a single coronary artery, and we finished the case in one setting. So I would like to just close by saying that anomalous circumflex from RCA from right sinus is always retroaortic in course. Anomalous RCA from left sinus is almost always interarterial in course, but rarely malignant. Interarterial course for LAD is usually malignant and rarely for right coronary artery. Most important view to decide to fall back on when you want to decide the course of anomalous arteries, of course, only in the left side, is the RAO. And the two biggest challenges of such PCIs are guide engagement and guide support, but that can be overcome by a little bit of wisdom, experience, and a little play of hands. Thank you.
Great presentation. Yes, as rightly explained about, it's an experience and challenging, of course, to do the PCI of the anomalous coronaries. For fellows, it's important to recognize that you are dealing with the anomalous coronaries instead of spending too much of time in localizing the anomalous origin of the coronary artery. One should think about that you are dealing with. There are certain signs like Dr. Sethi has rightly mentioned about a bare area for the L6 is the one you are not able to see the left coronary in the left sinus, and at that moment of time you should start searching for that are we dealing with the anomalous coronary, and then to go ahead. Here, I just want to add that sometimes the echo is also important to know about, especially for the anomalous LCX or anomalous left coronary from the right sinus, which is having a retroaortic course. You can have a straight line which can be visualized So whenever you do have a difficulty in the cath lab, you can have a look on the echo, where is the origin of this anomalous coronary, and then you can accordingly go ahead. There are certain cases when there is a need to go ahead for the CT angio done in case patient is not of acute coronary syndrome, just to become more wiser, to have a less of contrast and less of the fluoroscopy time to plan the intervention. Any question? Yes, Dr. Sastry, please.
Apart from the 2D echo or CT angio, sometimes you can do a IT root angio, DSA, to know things may be there. And second thing, after the advent of guideliners, it becomes easy. If you can pass wire, the guide support, you just pass a guideliner, your job is much easier.
Yeah, that's true. Guideliner adds to the support. Anything that adds to the support, guideliner, buddy balloon, buddy wire, anchor balloon helps. But what happens sometimes, we also have to realize that the first angulation of the anomalous coronary artery is not normal. It generally takes a very acute bend. So sometimes taking just the guideliner or balloon sometimes, or a large size balloon, or let's say a pre-used balloon, itself by its weight, disengages everything. So guideliner, if you can get it across the lumen and to a respectable distance, then it adds to the grade. But sometimes just pushing the guideliner itself might pull it back. So this is the two counterpoints that you have to take care of.
Another point is sometimes the RCA, it comes down
Yeah.
and takes. In my experience, Amplat's right.
Yeah.
Or sometimes it gives a very good support. It just sits there.
Yeah.
And then things becomes easy.
Yeah. So as I said, you should not go back with the image that for this particular anomalous coronary artery, this particular guide is better. You have to improvise, and whatever is helping you. One of the examples that we showed right from left sinus, it was RCA that helped us get across. So any catheter that helps you get across is beneficial. And those times when RCA is looking downwards, it sometimes, catheters that look down, like multipurpose, might be able to help you.
I'll just add on that excellent lecture. And the one of the important points which I really want to highlight again is that normally we tend to, as you said rightly, although guideliners and other things they help, but if the initial ostium is diseased, they don't allow anything to get in. Actually, everything gets backed out. Even if you are able to do it, the moment you put up a thing, it gets backed out. But if you push your guide catheter thinking that, it's going to somehow get engaged, you are in for a disaster. So he said one very good point is, when your wire is through, put a balloon. Whenever you have a balloon inside, not inflated, even just a balloon shaft, the catheter remains in the center of the lumen. It doesn't hit the walls. So dissection possibilities are minimal. So don't manipulate your guide if you don't have the balloon array. Only just by plainly, if you manipulate, you will dissect out quite often.
Just having a balloon, yeah.
Second thing is that you said complex science and but one other thing I should quickly point out whether it is an angle or circumflex is the lateral view. Because the lateral anything that posterior is always circumflex.
Yeah.
The anterior portion is an angle.
That's true. So I mean in the lateral view, the diagonals are going to, the LED is going to, and it helps us, as Dr. Rajesh lectures also pointed out, sometimes deciding between LED and diagonal, because the LED will follow this entire course retrosternal, and the diagonals will fall down, and the circumflex would be behind. The only challenge of taking a guideliner over the balloon is because the principle is that guideliner has to be taken over the wire, and then the balloon has to go inside, because then otherwise it changes. But the only thing is that I think just as Dr. Shiv Kumar said, the balloon, if it's inside over the wire, you have to imagine that it will act like a large, heavy, thick guide wire. The balloon shaft will act as a guide wire, and on that guide wire, you can clockwise and push the guiding catheter.